Yeah, thank you so much for a great presentation. And I'm now going to address some principal issues about mechanisms of resistance. And then we're going to discuss some patient cases and maybe bring up some additional points that have been already presented or discussed by the two previous speakers. So here is the mechanism of resistance to BCMA-targeted therapies. First of all, there is the dense tumor microenvironment. This is specifically true for extramedullary disease, where obviously T cells have an issue to really properly migrate into the tumor microenvironment. And so this is an issue of, or one cause of resistance. A second one is that obviously, in the tumor microenvironment, there are certain numbers of regulatory T cells that can suppress T cell function and thereby inhibit T cell-based therapies. And furthermore, because of the stimulation of the T cells in the tumor microenvironment, also T cell exhaustion can take place. Now, if we look at the different BCMA-targeted therapies, it's clearly that the 2 points on the right part of this slide, regulatory T cells and exhausted T cells play a major role for T cell engaging antibodies as well as CAR T cells, but do not affect BCMA-directed ADCs like belantamab because the drug is independent from T cell function. Now, the dense tumor microenvironment is clearly an issue for all BCMA-targeted therapies. Now, if we now look at the tumor intrinsic and extrinsic mechanisms, there are tumor intrinsic mechanisms. So there is the gamma secretase, which is cleaving the BCMA from the tumor surface, which decreases the number of target molecules. Then there is the loss of expression or downregulation of BCMA, which can also be to genetic alterations of the genes that are encoding the target antigen BCMA. And finally, there's also the increased expression of checkpoint molecules like PD-L1, which can again or kind of dampen the T cell function. Again, all these issues, especially the first two, address all BCMA target therapies. PD-L1 expression is only affecting CAR T cells and bispecific antibodies. And we know that target antigen loss is a real issue with bispecific antibodies. We know that about 50% of patients that are on long-term treatment with bispecific antibodies are losing BCMA. With CAR T cells, it's about 4 to 6%. And there are very few reports about BCMA loss following BCMA-targeted antibody drug conjugates. And then there are tumor extrinsic factors like soluble BCMA, which is inhibiting the binding of the BCMA targeting to the tumor cell. Again, there is CAR T cell exhaustion and trogocytosis, which is really restricted to CAR T cell therapy because then the CAR T cell expresses BCMA and induces some kind of fratricide. So again, these issues are mainly an issue for CAR T cell therapy. The soluble BCMA is clearly an issue for all BCMA targeting agents, probably less for CAR T cells. Now, here we analyze data about pretreatment. So if a patient receives ide-cel, we know that the overall response rate is 81%, the complete remission rate 39%, and the median progression-free survival 12.2 months. Now, if the patient has received a CAR T-cell product before, this doesn't seem to affect the efficacy. But clearly, bispecific antibodies and ADCs like belantamab, they are reducing the overall response rate to subsequent CAR T-cell therapy with ide-cel, and they are also reducing the median progression-free survival induced by a CAR T-cell product, here ide-cel. Now looking at the other CAR T-cell product, CARD21, cilta-cel, and again you can see that by giving a patient bispecific antibodies or ADCs prior to treatment with cilta-cel reduces the overall response rate, reduces quite considerably the rate of complete remission, and also reduces more actually bispecifics than ADCs, the progression-free survival. Now, in contrast, now looking at the bispecific antibodies, pre-treatment with CAR T cells and ADCs has some impact, but very little impact, only a modest reduction in the overall response rate and the CR rate when compared to patients that had not received a BCMA-targeted therapy before. Now we're moving to the toxicities of these different BCMA-directed agents. Now for CAR T cells and bispecific antibodies, we have the CRS, we have the ICANS, we have the macrophage activation syndrome with cytopenias, infections, and for the CAR T cells, in addition, some late neurotoxicities. Now we know by effective bridging therapy and reducing the tumor burden prior to CAR T cells and bispecific antibodies, we can reduce the likelihood and the severity of CRS and ICANS, and also reduce the likelihood of late neurotoxicities. And we also know that we need, for some of these issues, specialty consultations to optimize comorbidities. Now, in contrast, for example, to the ADC treatment with belamaf, we need antimicrobial prophylaxis, we need immune globulin replacement, and we would recommend to vaccinate these patients, because all the patients that receive bispecific antibodies or CAR T cells are losing their B cell function, and also quite a few also have a reduced T cell function. And then there is supportive care. We have to use antipyretics, analgesics, IV fluid to manage CRS and ICANS. Some patients need tocilizumab or corticosteroids for management of CRS and ICANS. And in second line, also anakinra and cetuximab, so anti-cytokine antibodies are used. And especially for patients that have a macrophage activation syndrome, also corticosteroids, anakinra, ruxolitinib, and in late lines, in very severe cases, etoposide and an anti-interferon gamma antibody are applied. An issue also following CAR T cell therapy, probably slightly less in patients receiving a bispecific antibodies, are long-lasting cytopenias that require the introduction of hematopoietic growth factors like GCSF, TPO, and some of these patients will develop infections, and therefore empiric broad-spectrum antibiotics are used in some of these patients, with the infectious disease consultation being involved. Now, what about the ADC? The ADC has no real issue with infectious complications. Some patients get some thrombocytopenia, but the main toxicity are ocular symptoms, and these ocular symptoms require to involve an ophthalmologist who is assessing the ocular toxicity. But this ocular toxicity can quite nicely managed either by reducing the dose of the ADC or by prolonging the treatment-free intervals. And it has been shown, and that's our experience, that especially by reducing the dose and extending the treatment-free interval, these ocular toxicities are reversible. It can take some time, in some patients weeks, but I have only seen patients in which the ocular toxicity completely resolved, and maybe we can discuss this later. And just now to see the key differences between the BCMA-directed therapy modalities, antibody-drug conjugates are off-the-shelf available, targeted cytotoxicity, not dependent on T cell function. They don't require lymphodepletion or corticosteroids. They are available also in the outpatient setting. Ocular toxicity have been discussed. there is some issue that patients that had a CD38 refractory disease are less likely to respond, and it requires continuous infusion. Now, this is the clear advantage of CAR T-cell therapy, which is once and done. It's a target immunocytotoxicity. It's a single infusion. There is some cases where CAR T-cells can persist for a long time. It requires a specialized center, knowledge about managing CRS and neurotoxicity. It can require, our experience, we haven't had any patients on ICU now for more than a year that received the BCMA CAR T-cell therapy, but neurological symptoms is an issue and requires neurology service, and it's clearly dependent on T-cell health. And there is some issue with risk of manufacturing failure, so out-of-spec products can be an issue, and then you have to regenerate CAR T cells from your patient. Now, bispecifics, again, here, no lymphodepletion, minimal corticosteroids, off the shelf available, not available at all infusion centers. At least in our center, we always admit the patient for the first, for the step-up dosing. There is a high infection rate with some products in more late-line therapies. The severe infections are extending or more than 40 to 50%. The efficacy depends on T-cell health, so there is the risk of T-cell exhaustion, and similar to the ADC, it requires continuous infusion. Now, key recommendations by IMWG and EHA-EMN, assuming equal access, CAR T-cell therapy is preferred over bispecific antibodies when both are options. Currently, more robust evidence for activity of bispecific after CAR T-cell therapy, so we should do our CAR T-cell therapy first, because consecutive CAR T-cell therapy could be inhibited by reduced T-cell function, or also by a reduction of the antigen expression on the myeloma cell, whereas most of the patients that had received a CAR T-cell therapy will still respond to a bispecific antibody. Bispecific T-cell redirection therapy is preferred ahead of BCMA-directed ADCs. And for patients who are ineligible for or unable to access T-cell redirecting therapy, the first choice is a belamaf-based regimen like BVD or BPD, as we have already seen. And here again is the rationale: bispecific antibodies retain activity when used after CAR T cells. CAR T cell collection may be compromised after prolonged B-cell bispecific exposures. ADCs do not rely on T-cell engagement, remain effective in patients with T-cell function dysfunction, and rapid disease progression or access limitations may necessitate using an off-the-shelf option first. To the next one, which is the first interactive case. And I'm going to present the case, and maybe we can then discuss this case also with the information that the different presentations actually contain. So Mrs. Jones is a 67-year-old patient with a relapsed refractory multiple myeloma. According to cytogenetics, she is a standard risk patient. She had received 3 prior lines of therapy, including an IMiD, a PI, and an anti-CD38 antibody. Now she's in clinical relapse, and for reasons we don't know, she's not eligible for CAR T-cell therapy. Now, the treatment options that are shown here is belantamab mafodotin-based combination, BCMA-directed bispecific antibody therapy, GPRC5D-directed bispecific antibody, IMiD PI-based regimen, other. So maybe we can start. Marie-V, what would be your first choice in this patient?
Well, honestly, if this is a triple class exposed patient, standard risk, and non-eligible for CAR T, I would say that belantamab mafodotin-based combination can be a possibility. It will be necessary to evaluate the sensitivity and refractoriness to bortezomib and pomalidomide because the patient is triple class exposed, or maybe BCMA-directed bispecific antibody therapy. And maybe GPRC5D is a possibility, but I will start maybe with BCMA, and I will not use in principle IMiD PI-based regime. So A or B.
Gordon, what would you be your choice in this patient?
Yeah, so I agree with Marie-V's analysis. What I would say is that also to remember that it's about availability or access to drug combinations, and that may well limit your choice as to which you would go. In our clinical practice, Mrs. Jones would definitely get a BCMA-directed bispecific antibody.
Mark?
Yeah, so I agree with both of my previous panelists. I think several of these are possible, A through C. Just from my impression in clinical practice, patients on BCMA-directed bispecifics tend to do very well in terms of quality of life, right? There is this increased risk of toxicity, which has to be managed. I think we've learned a lot since these initial trials. So infection rates with strict prophylaxis, both in terms of giving acyclovir, giving Cotrim, and also prophylactic immunoglobulins, have brought down these rates from what they were in the trials. And I think while this is still a concern, especially in patients with comorbidities and less fit patients, still generally if there's no infection, and then so the majority of the time patients do very, very well on this treatment. And that said, I would opt for the BCMA-directed bispecific antibody here as well.
Now, looking at the approval that we have in Europe, I think the only drug that is available is probably belantamab for this situation. So bispecifics are nice to have, but belantamab is, I guess, the drug that we have available. And I think it can be very effective in the combinations that we have seen. For me, BCMA and GPRC5D, I think BCMA, I would always use first bispecific antibody when compared with GPRC5D targeted, because I think the BCMA targeting is affected by less toxicity. I've seen several patients that have issues with loss of taste, with nail, and other issues, also some rare neurotoxicities. But in patients that have an infectious issue, probably GPRC5D might be my first choice. But again, belantamab is probably the treatment with the lowest infection risk. So that could be a very good option for patients that have some infectious complications in the past. So
just on that case, you're saying about access. In the UK, belantamab combination is only available at second line, so that patient wouldn't have been eligible for that.
Okay.
And our bispecifics are very much after line 3. Sorry.
Yeah. What about in Spain? I guess it's the same, right?
No, in Spain, it is not reimbursed yet, belantamab-based combination, but we can ask throughout compassionate use, and it is possible to use after after just one prior line of therapy. So there is not any limitation for just the first relapse. And bispecifics after, in the triple class exposure after 3 prior lines of therapy.
And now Mrs. Jones has actually received a BCMA-directed bispecific antibody. Then she relapsed again and was then put on a belantamab containing regimen, so BVD, and achieved a very good partial remission. Now, she developed some issues, some corneal issues. And now the question to our experts is, what would be our preferred management strategy with this patient having some corneal issues? Would it be to continue belantamab in a combination with VD at the same dose with ongoing monitoring and supportive care? Would withholding belamaf treatment until ocular recovery? Would it be switched to a reduced dose level of BVD, or D, to switch therapy completely, and E, other strategies? So maybe Mark can start this time.
Yeah, so I think the recommendations for handling of these situations are fairly straightforward here. I think you're recommended to withhold the belantamab mafodotin dose until the ocular toxicity recovers, and then an additional step can be to reduce dose level at another, if it reoccurs or even after the first occurrence.
So Gordon, what's the starting dose that you normally use belanmaf with, and what's the first? How long would you wait until you give the next dose?
So the starting dose is 2.5 the first cycle. Then we opt to 1.9, irrespective of the presence of toxicity. The thing is with toxicity as it develops, and particularly in this lady, her toxicity is getting more obvious with each passing cycle. Then it's actually the frequency of belamaf deliveries that makes the difference in my experience. And I've got patients who are actually getting belamaf dosing very infrequently, 4 or 5 monthly, and still having maintaining a fantastic response. So it's finding that patient-specific niche for that. So I would tend to do that.